So we want to welcome everyone who's joined us today. Today we're going to talk about an integrated analysis of metabolic and dietary SNPs with Dr. Penny Kendall-Reed and Feeding Your Genes with me, Morgan Knull. So Dr. Penny, when you're ready, we'll let you get started.
Absolutely. Thank you, everybody, for joining us. These are certainly strange times, and I think this is sort of the beginning of more and more webinars and telemedicine as we know it, which, one beautiful thing is that genetics certainly lends its hand to telemedicine. So I think we're right on the ball with timing here. From the first day in school, we're taught as practitioners to ask our patients about family history of disease with our patients. And why? It's because of genetics, of course. And we understand that family history increases the odds of developing that disease even before we knew about genetics. It just made sense. So I'm always blown away why it's still so hard to understand that people don't give genetics that full credence, and that it pretty much controls almost everything in the body, from the food that we eat to how we sleep. And because when it comes to weight, we are still so caught up in the calorie in versus calorie out, or the latest diet to hit the market. If any of you have been in my lectures before, you'll know that I love this slide, and with good reason, because it really hits home why we all can't eat the same diet and why our genetics make such a difference. These are two mice. The one on the left is FTO variant. The one on the right is FTO normal. These are 20-week-old mice. They've had the same diet, the same exercise, and the same sleep pattern for 20 weeks. And look at the difference in size. So clearly, we can't feed everybody the same genes or the same diet. Today, we're going to look at three different sets of genes: metabolic, carbs, and fats. These are the metabolic genes that we're going to go through. And I'm just going to touch in very quickly on the key points of each gene, because all of those key points are really well laid out in the GeneRx report. What I really want to show today is the importance of using genetics and how genetics completely changes how we would treat two patients who walk through our doors who have the same goal of perhaps losing weight or whatever the health goal might be. Their conditions look the same, but because their genes are so different, our treatment protocol is entirely different to how we get them to reach that goal. So first gene that we're going to start with is FTO. It's certainly one of my favorite genes, despite my poor coding in it. The normal allele is teal, the variant is A. And this is a gene which regulates ghrelin, leptin, and adiponectin. Those are our three main metabolic hormones that basically control satiety, hunger, and the rate of fat burning. It also stimulates, though, all the dopaminergic pathways in the VTA. And these dopaminergic pathways, when they're stimulated, they say to the brain, let's go seek out food. Let's start firing that pathway in the brain to go find food. And as we know, when we fire a pathway in the brain over and over again, we wire those neurons together, which is why FTO has such a hard time breaking patterns of going back to the fridge over and over again and seeking that behavior. So the A allele, the variant allele, has a much lower metabolic rate. In fact, they have an increased risk of obesity by 1.7%. They also have increased adipogenesis, which is the formation of fat from food. And it's because they can't turn off the production of two hormones, IRSI and 5, which basically just say, whatever's coming in here, let's store it as fat. And this gene expression is turned on particularly when we increase saturated fats and simple carbohydrates in the diet, or even if it's too many calories of the same good foods. MC4R is our next gene. The normal allele is T and the variant is C. This is the melanocortin-4 receptors in the hypothalamus, and it regulates out hunger versus satiety. And it does it by regulating the production of ghrelin versus leptin. So ghrelin, when it's high, as it is with the variant, it increases neuropeptide Y and agouti-related peptide protein, which then stimulates and binds into the MC4R receptor here and increases hunger. And again, those dopaminergic pathways to say, let's go find that food. With leptin, leptin is much lower in the variant allele, and what leptin is supposed to do is increase alpha MSH, inhibit neuropeptide Y, therefore bind into that MC4R receptor and say to the brain, great, I'm done, I'm satisfied, I don't need to go find food. The C allele even being heterozygote, so just having one C allele is going to increase obesity and BMI by 8%, entirely independent of diet and exercise. If you're homozygote variant, that increases up to 43%. These are the people that we can't treat through diet and exercise. We have to get at the leptin and the ghrelin through supplementation. Increased insulin resistance is also seen by 14%, and even more so if they're increasing sugars and saturated fats. And these are also the patients that when they're variant, you know how you have patients that when they go on an antidepressant or an antipsychotic, some of them gain a lot of weight and some of them don't seem to gain weight at all. It's the variants here who really blow up very quickly with antidepressants and antipsychotics. And a lot of it is because their brain is just driving them back to the cupboard over and over and over. They literally can't stop eating. And they also do certainly feel hungry. ADPOQ, there's two ADPOQ genes. ADPOQ genes code for the production of adiponectin, that third metabolic hormone that we saw in FTO. And adiponectin regulates insulin, glucose, fatty acid oxidation, and it also has an inverse relationship with inflammation, particularly in the blood vessels. The first ADPOQ gene, the normal allele is G and the variant is A. And the variants here, they have a really decreased production of adiponectin when they're trying to lose weight. So these are the people, even if they're following their genetic diet and what they're supposed to eat, they still have such a low production of adiponectin that once again, we really need to support them with supplementation. We can't just target it through diet. They also have an increased production of it when following it. And the variants here will have an increased weight, BMI, diabetes, and food cravings as well. The secondary ADPOQ genes, the normal is A and the variant is G, so they're reversed. The last ADPOQ, the normal was G. And here, these are the variants who don't produce a lot of adiponectin when they're cheating from their genetic diet or when they try to go into weight maintenance. So those are those people that yo-yo in diet all the time. They have the up 5 pounds, down 10 pounds, particularly when they cheat, even if the cheats seem pretty small. So those are the people that if they're normal for the first ADPOQ gene, we actually don't need to support those hormones during weight loss. It's after the weight loss when weight maintenance begins that we need to watch out for those hormones. ADRB2, there's a whole family, there's 7 androgens, and they all code for stress hormone receptors, and there's a wide distribution of them all through the body, but this specific one has a high number of receptors in the fat cells. So this basically determines how the body responds from a weight point of view in terms of lipogenesis and mood and response to diet, how well it burns, etc., when under stress. And this is why we always see when people are stressed, they have those food cravings, particularly the sweet cravings. It functions through this gene because stress is dessert spelled backwards. So the G allele, which is the variant allele, has much more sensitivity when they're eating carbohydrates and sugars. They have decreased weight loss, particularly when they're doing endurance exercise. So they need to do a little bit more on the high intensity interval training or much longer endurance performance. They have increased production of inflammatory cytokines because we know that the stress hormones do that, particularly interleukin-6, which targets the fat cells. And when interleukin-6 is high inside the fat cells, it attracts more fat into it. And a really large leptin production. And leptin, as we know, is that hormone which comes out at the end of the meal to say, great, I'm done, I'm satisfied. So stop making me want to seek out food. It is also a fat burning hormone. So when people are stressed, they're often really good with their diet during the day, but if they have a G allele, heterozygote or variant, their leptin is so altered that those are the people that can't stop eating after dinner. Even if they're not hungry, they're still going back to the fridge over and over and over again. PPAR gamma, this is a really interesting gene. The normal allele is C, the variant is G. And what this regulates is insulin sensitivity and glucose levels and thermogenesis. It also plays a large role in inflammation, particularly again in the blood vessels. And it has a big impact on inflammatory cytokine production, interleukin-6 and TNF-alpha in particular. PPAR gamma is known as the master regulator of adipocyte biology. And what this basically means is it has a huge role in, or a hand in affecting so many other metabolic genes. PPAR gamma makes a protein that when it makes that protein, it goes over to almost all of the other metabolic genes and alters their transcription. Sometimes, depending on the gene, it alters it in a good way, sometimes it's in a bad way. So we'll see with this gene, we're going to go through both alleles because both alleles have a good and a bad side to it. So the G allele, this is considered the variant allele because it's not the ancestral allele, but it's not actually the risk allele. These people actually have improved insulin sensitivity, they have a decreased risk of diabetes and heart disease, but they're much worse on a high carb, high saturated diet than the other allele is. So what this basically means is that the G allele has a better control of blood sugars and a decreased risk of diabetes and weight when following a low carb diet. But as soon as they start increasing the sugars and the carbs, the process of weight gain and diabetes begins, and it progresses at a much faster rate than the C allele would. Whereas the C allele is considered the normal allele, but it's actually the risk allele when diet is better. They generally have a higher BMI, they do have an increased risk of diabetes, and they are worse on a high carb, high saturated diet. But they have a lower risk if they are keeping their diet, if they have a little bit more carbs, they have a lower risk of getting that weight gain and diabetes. And they can control it really well through exercise, which the G allele cannot do. So let's put all of these genes together and see how they interact. And we're going to go through case studies looking at these two. On the left side, we're going to see true metabolic hormone weight gain. On the right side, with these set of genes, we're going to see the metabolic hormones are actually not that bad, but the genes themselves are triggered by stress and PPAR gamma. So we have two different scenarios of the same genes. Both people have gained weight. Both people are looking to lose weight, but their treatment is entirely different. So the first one is a 53-year-old female. She gained 32 pounds over the past 5 years with large food cravings, especially for sweets and fats. She'd always struggled with her weight, but if she reduced her caloric intake, she could lose some, but not this time. She was doing 3 meals a day with no snacks, lean proteins, balanced whole grains, no simple sugars, and low saturated fat. So pretty good overall diet. But if we look at her genes, FTO, she's AA, so she's that variant with alterations in ghrelin, leptin, and adiponectin. Her MC4R, she's TC, and remember, having just one C allele there is going to increase the weight by 8% right off the bat. Her production of adiponectin during weight loss is slightly lower because she's heterozygote. Her production of adiponectin with weight maintenance is really low, particularly if she deviates. Her stress response, completely normal, and her PPAR gamma response, it's variant, but again, not the risk allele, so considered normal. So what do we have to do here? We have to target those 3 metabolic hormones. So we're going to use TMC, or trimetabolic control, which is the dolichos biflorous piperbetyl and acetyl L-carnitine, to target the leptin, adiponectin, and ghrelin. We're going to do 2 caps BID, 30 minutes to an hour before lunch and dinner, for about 8 weeks. I'm going to move her, keep the diet relatively the same, but move her to intermittent fasting with 3 cycles of fasting mimicking diet to start off, a 5-day cycle once a month for 3 months. She started dropping 2.5 pounds weekly until she had lost 38 pounds. At this point, we reduced her TMC to 1 week out of every 3 weeks. Normally, I would do a 4 to 6 week rotation, but because she was variant for FTO and heterozygote for MC4R, the 2 big ones that need the TMC here, I made the rotation much smaller, particularly because of that MC4R. So put her to 3 weeks. Kept her on her intermittent fasting and rotated in the fasting mimicking diet 3 times a year after she had done the initial 3 cycles. 7 years later, she had maintained her weight loss. Her food cravings and her control for weight were much better even when she indulged. So again, the beauty of genetics, as we'll see, is it's not just a 3-month control of behavior or a 1-year control of weight. We get this longevity with patients, which is absolutely amazing. So let's look at the other side of this. Oh, sorry, this is acting up. There we go. So the other side of the genetic equation here, the case study 2, a 31-year-old female. She graduated from med school 2 years ago. She was very stressed during school, and it was much worse now. She was sleep deprived, sleeping only 5 hours a night, waking at that cortisol witching hour at 2:30 in the morning. She had always been slim, but she gained 11 pounds in the past 4 years with no change in her diet or exercise, and then a rapid weight gain of another 13 pounds in 6 months. Her blood sugars also began to rise fairly quickly. So here we see her FTO. She's normal here. So she's got a good ghrelin, leptin, adiponectin, and a good metabolism. MC4, also normal. Fast metabolism, normal hormonal response. Her ADPOQ, while she's eating her genetic diet, completely normal. Her ADPOQ during weight maintenance, or if she cheated, pretty low though. Her stress response, heterozygote, so increased weight, genes blocking other stress genes as well and blocking other metabolic genes, because we know that cortisol, like PPAR gamma, will go over and alter 90% of genes, so it'll shut off her good TT-FTO and her good TT-MC4R. And her PPAR gamma, and metabolically, because we have the normal gene, which is actually the adverse gene here. So here, we don't need to touch those hormones per se, we just need to get at what's altering those hormones, which is the stress and the PPAR gamma. So we're gonna use the Seronetin plus 2 BID for 4 weeks. Then we're gonna reduce that to 1 BID, empty stomach, increasing as needed for stress. We're going to use the resveratrol, 150 milligrams BID, empty stomach for 8 weeks. That's how we're treating the PPAR gamma. The Seronetin is to treat the stress hormones. No change in diet here at all. She lost 8 pounds in the first month and 4 each of the following months until she'd lost a total of 27 pounds, so even more than she had started with. 5 months later, she had a big stressor, but she didn't increase her Seronetin at that time because she was on her maintenance dose then, and she gained 3.5 pounds back. She returned, we increased the Seronetin back to 2 BID for 4 weeks, and her weight dropped again, so she learned how to manage her weight from there. Carbohydrate genes. So 3 genes we're going to look at: TCF7, IRS1, and GIPR. TCF7, the normal allele is C, the variant is T, and this codes for a protein which alters the expression of all other genes that deal with insulin and carbohydrate sensitivity. So it's a huge gene when we're talking about carbohydrate consumption because of that factor. And it's one that when one is variant, again, there are sugar cravings that you just can't stop because the insulin sensitivity and carbohydrate sensitivity is so high. It almost becomes that zombie-like, I have to have it. They literally can't stay away from it. So the T allele, which is the variant allele, this is the largest risk factor for type 2 diabetes. Being homozygote variant has an increased risk by 2-fold and heterozygotes by 1.4-fold. So that's pretty significant. And it's literally because it is involved in signaling every other gene with respect to insulin. IRS1. IRS1 is insulin receptor substrate 1. And what this does is it does play a huge role in the production of insulin as well upon the consumption of carbohydrates. But it is also the major protein that gets activated and triggers IGF-1 and P13K. So P13K are those pathways involved in cellular differentiation and replication, similar to IGF-1, and these are the big cancer pathways. So these are the people that are really susceptible to increased risk of cancer upon carbohydrate consumption. So the C allele, which is the variant allele, they do have a big risk of increased obesity and BMI. But my bigger concern for these people is the risk of colorectal, lung, prostate, and breast cancers. It can increase the risk of initiating that cancer as well as the progression of all of those cancers. And this is, again, one of the reasons why we see some people and their tumor markers respond really well to dietary changes, and some other patients don't. It really doesn't seem to affect their tumor marker levels or the progression of the disease. This is one of those big genes for that. GIPR is gastric inhibitory polypeptide receptor. The normal allele here is C, and the variant allele is T. This is a protein which, when produced, it inhibits the release of gastric acid and gastrin in the stomach and in the GI tract. So it causes a great deal of inflammation in the GI tract, and it's also one that alters insulin and glucose levels once again after carbohydrate consumption. The T allele, which is the variant allele here, again, a large increase in insulin following carbohydrate consumption, but a lot of gastric and intestinal inflammation. And this is often mixed up with people who think that they have a gluten sensitivity, because gluten is only found predominantly in carbohydrates. And when they pull out, when people used to pull out carbohydrates years ago, even if they were variant for this allele, they generally noticed a really good response to it, because we didn't have all those sort of fake-free, gluten-free products that we now have, which are still filled with carbohydrates, which is exactly what these people are responding to. They're not responding to the gluten in it. They're actually responding to the disaccharide in it and generating that inflammation. So this is really important when people think that they're gluten sensitive and they're still consuming a lot of gluten-free products. It's often the disaccharide from the GIPR gene. And when they do that, they're still going to keep increasing their obesity and diabetes, because there still is that carbohydrate in that gluten-free product. So comparative integration here. What we're going to see on the left side is that it's less dietary related, the weight, and it's more stress and FTO's sensitivity to carbohydrates. Whereas on the right side, we're actually going to see it's more food related. Yes, made a little bit worse through stress, but the real treatment on the right side comes down to diet. So we have a 48-year-old perimenopausal woman. She gained 27 pounds in 6 months and no change in diet or exercise. She'd never been overweight in the past, and she had difficulty sleeping in the past, waking at 2, again, that witching hour, and 4, cortisol's second witching hour. She dropped all the sugars, starchy vegetables, grains, fruits, and when she did that, she gained even more weight. So if we look at this, her TCF7L2, that big diabetic guy, she's completely normal. Her IRS1, which is again that production of or stimulation of the P13K pathways and the IGF pathways, little bit increased sensitivity here, insulin-wise and cancer risk. And the GIPR, completely normal again, insulin-wise for carbohydrates and no GI inflammation. Her FTO, though, was variant, and her stress response also variant. So that is going to start to trigger off some of the food genes. So once again, what we do is use the tri-metabolic control here to get at the FTO that is variant, 2 caps BID for 8 weeks, and then we're going to rotate it in 1 week out of every 6 weeks. I pushed it back to 6 weeks because her MC4R gene was normal. And then we need to get at that stress gene, so we're going to use the Seronetin Plus 2 BID for 10 weeks, and then reduce it to 1 BID, increasing as needed. So with her, what was going on was that perimenopause had stimulated her variant androgen, because we know when we go through perimenopause and into menopause, just as naturally as estrogen and progesterone fall, cortisol rises. So we start making more stress hormones for the same stressors. And that was her issue. She had kept her FTO gene in its off position, but when perimenopause hit, that increased cortisol and that started tipping off her FTO gene. And that increased cortisol from perimenopause tipped off the androgen, which just inflamed that whole scenario. So her weight gain really had nothing to do with her diet because she handled the carbs well. So we didn't need to change her diet. 1 month later, she had dropped 8 pounds. 4 months later, she had dropped 33 pounds, and she'd kept it off for 5 years. The other side of this comparison, we have a 28-year-old male. He moved out of his parents' house a year ago. He gained 18 pounds in 2.5 months, despite exercising 5 times a week. He'd increased the simple carbs, things like pasta and rice, because they were easy to make and they were cheap. He had always eaten those foods, but in smaller quantities and in the past, and he'd never gained weight. So he was pretty confused by that. When we look at his genes, TCF7L2 is variant here, so the increased insulin response to those carbs. IRS1 also variant, so increased insulin and cancer risk. And the GIPR heterozygote, so once again, increased insulin and some GI inflammation. His metabolism was completely normal. His FTO was really high, and his stress response was heterozygote, so a little bit increased obesity there. But you can see the main focus of it here is his change in diet when he moved out of school and how that started affecting his weight. So we reduced the carbohydrates to 1 meal per day, keeping the size of that carb, which is the breads, the pastas, the grains, the starches, the fruits, the sweets, etc., to half the size, the physical size of his protein. Eliminated completely the sugars and the fruits, and didn't need to use any supplements at all. He lost on average 2 pounds a week until he had dropped 20 pounds, and then he didn't want to lose anymore. We added in magnesium and increased fluids to help combat some of the sugar withdrawal initially. We added in carbs at a second meal, still half the size of the protein. Fruit and sugar is still on occasion. And by doing that, he maintained his weight for the past 7 years, even when a stressor had hit him. Last section of genes we're going to look at today, the fat genes, and there's 3 of them: APOA2, FAB-P2, and FTO. So APOA2 is it's a gene which, similar to the FAB-P2, it basically looks at how the body and how the bowel handles saturated fat. Does it increase more than the normal amount of absorption from it? Does it also increase cholesterol production? Does it increase weight gain? Why I've written here normal and variant having 2 alleles is because 23andMe often uses the reverse strand when they're testing of the DNA, and research will often use the positive strand. And this is one of those cases. So if you go and you look at research, you may see A or G, or you may see T or C. So I'm giving you the normals and the variants for both of them. With APOA2, because they have so much ghrelin increase, particularly when increased saturated fats, they start that food craving again. They start those dopaminergic pathways of, I have to. So APOA2, the variant G or C allele, these variables of weight gain, increased cholesterol production, increased inflammation will only be triggered when the variants are consuming more than 22 grams of saturated fat per day. They have an increased BMI by 6.2%. That's huge when consuming saturated fats more than 22 grams per day. Variables in the heterozygotes are triggered when consuming more than 28 grams of saturated fat per day. So we missed a slide there. No, sorry, FAB-P2. Very similar to APOA2 in that it deals with the transportation of fats, but it does it through fatty acid binding protein. And this will specifically bind long chain fatty acids in the saturated fats, pull them into the blood, and have an effect on weight gain. Variants here have twice the affinity for pulling in these fatty acids and increasing their absorption. So they have an increased absorption when they're consuming 53 grams of saturated fat per day. And I know that that sounds like a lot, but if you're doing a bulletproof diet or a keto diet, 53 grams is actually not that difficult to achieve. With this, they'll have increased fatty acid oxidation, increased insulin release, and increased diabetes. So when we look at a comparison here, this comparison is even tighter. Here, the difference is only 1 gene, but it has a really significant impact. The left side's pretty good with saturated fats, essentially no limits, but the right side needs to rein them in a good deal. So now let's take a look at 2 people who are following the same diet, but they have completely different genes, and let's see what happens. So the first is a 24-year-old student. She started a bulletproof diet with her friend. She felt hungry and had increased food cravings, but she's continued on it the whole time. Initially, she lost 4 pounds, and we always see this when we are putting somebody on a bulletproof or keto diet at first, because you drop all the sugar. You drop all the sugar, you're absolutely going to lose weight at first. The key is, do you keep that weight off? Do you start increasing inflammation, and do you start gaining weight? And that's what she did. She then gained 13 pounds over a 4-month period. She felt really puffy and inflamed all the time. And prior to her diet, prior to doing this diet, she was eating balanced proteins and carbs with lower saturated fat. So a very different diet than bulletproof. So when we look at her genes, her APOA2, she's variant. So she's going to get that inflammatory weight gain cholesterol response when she eats more than 22 grams. Her FAB-P2 is heterozygote, so again, poor with saturated fats. Her FTO, completely normal, so she actually had a fast metabolism. Similarly through her MC4R, completely normal. So this one's all diet related. So here we reduced her saturated fats to less than 22 grams per day. Dietary changes that are what we can make to make this very easy is get out all the coconut and MCT oil. 1 tablespoon of either of these is 16 to 17 grams of saturated fat. Then if you put in like a tablespoon of butter or ghee, which people are doing in their bulletproof coffees, you've now put that person up to 24 grams of saturated fat just with the coffee first thing in the morning. And if they're variant for this gene, as she was, right away she had triggered that gene, which means for the rest of the day, she's going to store anything that she eats, doesn't matter if it's got fat in it or not, as fat, increase that inflammation, and increase hunger all the time through ghrelin. We also swap out peanuts and cashews and Brazil nuts for more almonds and walnuts. Really good option because 30 almonds only has 1.1 gram of saturated fat. So we're going to get a decrease there. Swap regular fat dairy products for organic fat-free, particularly the Greek yogurt and the cottage cheese, because then once again, we have dropped out that saturated fat, and reduce meat to about twice a week, red meat. If you make those changes, it's much easier with our patients to, rather than saying to them just 22 grams, just to give them guidance. If they do that, these changes here, it's pretty hard to eat more than 22 grams per day. And this is why keto is not for everybody. Again, this is a good example of saturated fats and what we need to sort of rein in. And so if we make those changes prior, we don't need to worry about the 6 grams that are coming in the salmon, or a little bit if they're going to have some cheese, or we do have to look at the dark chocolate though. There is almost 10 grams in an ounce of dark chocolate, so we can't go too crazy with that one. The next case, within 1 week, she lost 3 pounds and she felt far less puffy. At the end of the 6 weeks, she dropped 12 pounds. At the end of 10-week mark, she dropped 18 pounds and she felt great. Her energy was high, she had no inflammation and no food cravings. We look at her friend though, the 33-year-old friend who she started this bulletproof diet with. She had lost 23 pounds over 2.5 months doing the bulletproof, and she felt great. Her mental and physical performance improved, and so did her sleep. And this is because she was normal for APOA2. So this is the one gene difference between these two people. So she didn't have to pull in those saturated fats beyond the 53 grams because her FAB-P2 here was heterozygote. Had that fast metabolism, also not stimulated by saturated fats because the FTO is normal, and similarly with her MC4R. So for her, she was designed for bulletproof and keto. Very small group of people that are truly designed for this particularly long term. She would have to exceed that 53 grams in order to stimulate the adipogenesis or inflammation. So for her, no change is needed, but we can see how this completely changes our treatment just from one gene between the two people and the effect that that has on those two people. So when we put this all together, our body is one unit. When you change one area in the body, you are going to change another area. And this is why the integration of genes is so important. You can't just trait one gene on its own, because for one gene, you may turn off another gene. And that then has an influence on turning off another gene in that same health category. It's also crucial to make sure that we, just because we have a gene, doesn't mean that we are coding for that gene or expressing that gene. So this is where we have to look at our patients and say, you know what, I don't think that you're expressing this gene. Just like some of the examples we saw in the case studies, they weren't expressing them prior to perimenopause, so we don't really need to touch anything prior to that. We need to wait until they're expressing it, unless it is a family history risk. And again, I putting all of these pieces together, marrying them with the patient that is in front of us, marrying them with our labs, this is what gives us that true glimpse inside of a body, allows us to look at that patient and know what is going on, why those two patients coming to our office are presenting with the same thing, not responding to the same treatment that we're giving them. And it's also It's so reassuring to patients because at the end of the day, they truly know what is designed for them. Because the majority of them, if they're coming in for weight loss, they've tried almost every diet out there and they still haven't succeeded, which is why they're in your office. Even if they've succeeded with weight, they're still trying to control their food cravings. So there's some aspect that we can truly, truly help them with. So I thank you for listening to this part of the lecture, and I now pass it over to the second part with Morgan.
Awesome. Thank you so much, Dr. Penny. As usual, that was just extremely informative. So today I will be talking about feeding your genes. And I'm hoping that everyone can see this. Penny, can you see my
Yep.
screen?
Perfect.
Okay, wonderful. So genetic meal plans, and let me just put the chat to the side here. Sorry, guys, I want to make sure I'm seeing it. Perfect, thank you. So how including a customized dietary program can maximize the metabolism and health of your patients. Oops, my screen's not moving. Sorry, guys. There we go. Although Penny just explained it so well for us, a little bit about, so science is evolving and it's become clear that there is not one perfect diet for everyone. What makes us different? Our genetics. So today it's common for people to adopt diets based on popular fads that might not be ideal for them as individuals. For many people, popular diets such as ketogenic and high protein, they tend to work at first as a result of removing sugar and carbs, but then plateau. And this is what happens when we don't feed our genes properly. For an example, depending on how you code for APOA2 and FTO SNPs, both crucial in metabolic function, you may need to lower your saturated fat intake to almost a quarter of that of the ketogenic. Others have been told that a high protein diet will help them reduce body fat when certain genetic factors can create an environment for that excess protein to turn into fat. Have you ever seen a gym buff who looks like they have a layer of fat on top of their muscles or in their face? They're eating too much protein. So data required to feed your genes. We're basically looking for 5 key pieces of information. Carbohydrates, sensitive or not sensitive, fats, and we're looking at the integration of the SNPs that Dr. Penny shared with us earlier, and then protein. So that's going to be our genetic predisposition amount that we find on our GeneRx report times your weight in kg, and that'll give you the grams of protein per day. I also want to take a look at sensitivities before I create a meal plan for someone or guide them through a genetic diet, as well as fasting. So for some people, we may want to start off with 8-week intermittent fasting. And for others, it may be more important just to do timed feeding and to keep 6 hours in between their meals. So when someone's sensitive to carbohydrates, we're going to limit the grains, starches, fruits, and alcohol, and the physical size being 1/2 to 3/4 of the protein plated. So if you look at the palm of your hand, and that's, let's say, the size of a chicken breast that you're about to eat, 1/2 of that size is what you can enjoy with those starchy carbs or grains. But then you can fill your plate up with all the delicious healthy carbs, the salads, the cauliflower, broccoli, zucchini, and peppers. And in a lot of cases, those cruciferous vegetables are going to help a lot with our other SNPs. So for the fats, this is just a quote right out of the GeneRx report. Some simple changes that can be made to lower saturated fat intake and maintain poly and monounsaturated fats include consuming almonds and walnuts over most other nuts, using fat-free dairy products such as yogurt and cottage cheese, and using almond or avocado oil, and eliminating coconut oil, and consuming more poultry and fish versus red meat. So based on our genetics, the amounts of daily saturated fat intake are going to be 23, 28, or 30 grams per day. And that's based on the FAB2, APOA, and FTO SNPs. But unlike protein, we are not trying to achieve this number daily, but trying to avoid it. So this means that if someone is required to stay within 23 grams of saturated fat per day and they only have five grams that day, that's perfectly fine. So for protein, the method is going to be the genetic predisposition times weight in kilograms. So let's take, for example, that someone is a heterozygote for FTO and they're 75 kgs. Well, for heterozygote FTO, that's between 0.8 and 1 gram of protein per kilogram. So you times 75 by 0.8, and again 1.1 by 75, and your grams are going to be 60 to 75 per day. You want to make sure this is divided equally into your meals. So this isn't to say don't eat protein all day and then have a 16-ounce ribeye at the end of the day. That's not going to do what we want it to and help us to control those hunger hormones. So let's say it's 60 grams per day and it's 3 meals per day. Try to get as close to as possible 20 grams per meal. And a note about protein, for genetic diets, from what I'm seeing, the protein is a lot smaller than we think. So for example, 20 ounces of protein is roughly about 3 ounces of chicken. That's only about half a chicken breast. And when I'm sharing this with clients, they're usually a little bit weary because they have previously been on diets where protein has been 100 or more. And in some cases, we're cutting that protein to almost half. The advice I give them is just to try it for a week and see how they feel. After that week, I have never had anybody complain. In fact, what I do hear is that they feel better, less inflamed. They feel less cravings in between meals. And they're also happy that they're saving a few bucks on their grocery bill from the less amount of protein. So a little tip there. When I'm creating a customized program, I always want to put a summary together of what it's based on, GeneRx report, how many meals they can have, whether snacking is okay. And as a hint here, may have coffee or tea in between meals. Take a look at their GeneRx report, because one of my favorite things about the GeneRx report is it's very specific about coffee. You'll know whether you can have 1 cup or 3 cups a day. And so that might help support your clients as well. We've got the protein allotment and then just their guidelines and always the goal at the bottom. So I put together a couple really quick case studies to share with you guys so that you're able to see how implementing a genetic diet for your patients can impact their health. So we've got a 32-year-old female. She gained 25 pounds over 2 years of high stress, poor diet, and lack of exercise. Most of her main meals were paleo style, with constant snacking of salty foods, those nuts, chips, and cheeses. So right away, I'm thinking FTO, or I'm thinking DRD2, and I'm going to want to look at those dopamine and snacking SNPs later. Her goal is to lose weight, increase energy, stop snacking, and feel more energized with mealtime. So with her program, we reduced her protein to 63 to 68 grams per day, which is 2 meals consisting of lunch and dinner with fasting for 16 hours. Limited starchy carbs with lots of unlimited vegetables. Her saturated fat was under 23 grams per day. So after 10 days, she was down 5 pounds. She still had the urge to snack, but was feeling excited with new flavors and the simplicity of recipes. So, and I'm always recommending the TMC product for those snackers as well. After 3 weeks, she was down 8 pounds. She had less cravings, more energy, is batch cooking meals and freezing them for convenience. She feels that having a program helps to keep her organized and has reduced the occasional heavy carb meal that didn't make her feel good. 5 weeks in, she's down 12 pounds, eating half the volume as before, with more enjoyment of food and meal prepping days. Now with 0 cravings or urge to snack. Stress has been reduced and is feeling more optimistic about weight loss process, and she doesn't feel like she's dieting. 30-year-old man, he gained 10 pounds over the past year since playing less sports, has been getting sick more than before with colds and general rundown and low energy. About 3 months ago, he started the keto diet with very high protein. He's not lost any weight and felt more run down and tired. His goal was to lose the weight, increase energy, and support genetics through nutrition. His protein was 84 to 94 grams per day, divided equally between 3 meals and no snacking in between. So keeping that those timed meals at the 6 hours in between each meal. Limited starchy carbs with lots of allowed vegetables. And his saturated fat had to be under 23 grams a day. So as you can see, he was actually on the lower end of what would have worked for him for saturated fat, and a keto diet would have probably just been too heavy for him. After 10 days, he was down 7 pounds, started to feel more energized during the day. After 3 weeks, he was down 10 pounds, feeling less stressed about food. He enjoys cooking again and has much more energy. After 5 weeks, his goal to lose 10 pounds was achieved. He feels enjoyment in meals, and he's not feeling run down or sick. Lastly, we have a 48-year-old female. Her challenge is to maintain healthy weight while enjoying food and meal times. Has become extremely bored and almost disinterested with repetitive meals. So she was already on genetic guided recommendations and had been creating her own meal ideas based on those. So the goal was to maintain that healthy weight, reduce inflammation, and enjoy preparing and eating food again. Her protein is 36 to 44 grams a day divided by 2 meals with intermittent fasting. Limited starchy veg, lots of allowed vegetables, and under 28 grams of saturated fat daily. So she's a little bit more on the higher side there. After 10 days of her meal plan, she's feeling a noticeable shift in excitement around mealtime, and she likes to pre-order groceries and cook something different each night. At 3 weeks, weight and inflammation are maintained, is happier knowing her meals are designed and planned so she does not have to think about what to cook every day. And at 5 weeks, her body is feeling stronger than before, and she is rejuvenated by a meal plan that excites her. Is now on a second rotation of a 4-week program and is happy with variation of foods and flavors. So included in this is, or how I put it together anyways, will be 2 to 3 meals, grocery list, recipes per genetic requirement, weekly, bi-weekly, or monthly programs, handouts and tips, additional coaching and consultations if needed. So I'm going to make my screen a little smaller here and pull up an example of what that looks like. Penny, can you see that?
Yes, I can. Absolutely. I see the smaller screen of your presentation, not the new screen yet.
Oh, do you see the Feed Your Genes report?
No, not yet.
Okay. Let me get that.
I can easily say though that Morgan's recipes, when you first get a patient and you just tell them their parameters with their diet, there's 2 things. One that seems like really difficult to stick to, or 2 that seems very repetitive. When you see Morgan's recipes, you honestly feel like you're eating gourmet every day. They're absolutely fantastic. And because it is all laid out with a shopping list, you actually spend less time in the grocery store, less time thinking. They're fantastic.
Thank you, Penny. So I think you can see it now, right?
Perfect.
So this is what, and I'll just go over it really quickly with you guys so that you can see the cover page that I'm talking about here for people. So I'll say, why you've decided to feed your genes, and then some tips for success, like, purchase a scale and use it for a week until you're comfortable eyeballing out your protein. If you want to freeze some meals, if you like a meal and want to eat it a few nights in a row, go for it. Just keep it simple. And then that customization is at the bottom. You'll see that we have a schedule here. And you can see the chocolate paleo smoothie comes up a lot. I'm obsessed with the Designs for Health protein. And then here we go. Exactly. So we're looking at the protein amount here on the bottom, and you can see we're well within the range. Now, when we go to the top and we're looking at saturated fat, as you'll see, The highest this one gets to is 17 grams a day, and that's well under the 28 grams that would cause trouble. Carbs are low, but if you see the carbs like on Saturday and Sunday, they look equal to the protein. That's because this isn't deciphering between the simple and complex carbs. So we have so many good vegetables that are counted in there. This is my favorite part for the shopping list, that you can recommend that people go online. Like I spend probably 10 minutes on a grocery store website. I order all of this up, and then I pull up into their parking lot, call them, and they bring the groceries out to me. It is such a great way to be able to do this. So I'll get out of here. Oh, I hear there's some trouble hearing me. Can you hear me now?
I can hear you now. Just it cut out twice on my end. Perhaps it was just mine.
Oh, okay. Sorry, guys. I'm almost done. So just a couple announcements here. We are doing an Instagram giveaway. So you can go to feed.your.genes, and we're going to announce the winner this coming Monday. So the winner gets a free GeneRx report with a 1-week Feed Your Genes meal plan. You can use this for yourself or for a patient. And then the last thing is, our next webinars are May 1st for cardiovascular and resistance training, and June 5th for phase 1 and phase 2 detoxification SNPs. And please feel free to just shoot me an email if you're not yet registered for those 2 upcoming webinars, and we'll get you on there. So the last thing we want to do is open it up to questions. So I am going to look at the chat. If you can please post any questions you have for myself or Penny, we are more than happy to answer them for you. Someone says her recipes are delicious. I just made one yesterday for dinner. Thank you.
They truly are. They truly are amazing. You know, I don't know, I'm hoping a lot of you are using genetics already. It really is a huge impact. I've never had a patient come back and not have a fantastic result, not just with weight, but with everything. When you start tweaking the major pathways, whether they're the inflammatory, the detoxification, the hormonal, the neurological, other variables that patients didn't think about start to fall into place. But it truly does start with our diet, which is why Morgan and I chose to start with this one.
Exactly. Dr. Penny, there's a question here. Is 23andMe the only testing that can be uploaded into GeneRx?
Yes, it is right now, because I couldn't find many other platforms, testing platforms, that had all of the genes that I needed, and I'm going to continue to keep adding them. The sleep section was the newest section that was just added. I will be doing a thyroid section and a GI section. So I always have to keep in mind what other platforms have the genes that I need moving forward. It's also one that is accessible, that patients can purchase on their own first if they want. So it's not an added expense at the office. And it's also one of the cheaper ones that I can get all of the genes on.
Okay. And how do our patients go about access to your program, and how much is it? I don't know if that is for which one of us that's for, so maybe we should both answer that question.
So for me, GeneRx is not available for patients. It is only for doctors, healthcare practitioners, and personal trainers. There is a healthcare practitioner report, which is $250, and there's a trainer report, which is $100. The trainer report has all of the dietary, metabolic, exercise, and stress genes. So if you're just looking to do weight loss and exercise with someone, you can just do that and then still filter that into Feed Your Genes with Morgan. There used to be the price right on the homepage, but that has been since removed, and the price of the reports are seen when you start to set up your account. And that was so that your patients didn't go on and see GeneRx or look at GeneRx and say, well, if it's $250, why are you charging me blah? The other variable or caveat is that will be coming in about 2 weeks time, 2 to 3 weeks, is you'll be able to add your own, customize your own logo and put it on the GeneRx reports.
Okay, and then as far as I go, there's 2 different ways to to access a Feed Your Genes meal plan. So the first is that you contact me directly as the healthcare practitioner, and I sell a meal plan to you directly for your patients so that you can continue working with them. The other way, if you would like them to get some additional coaching, I do have, great people that I work with as well to do nutritional counseling and things like that. And I will be certified not too long now from the nutritional counseling side of things. So you can refer them directly to me and to my website. Or like I said, I'm happy to support you practitioners with those plans to sell to your patients. There's another question here. Does your recipes take into account patients' food sensitivities and or allergies? Absolutely. So I usually give a meal plan intake form. So not only do I take into account all of their genetic requirements, their sensitivities or their allergies, but also I work in their likes and their dislikes and their time they want to cook and stuff. So if someone's like, I want to cook one meal and eat it for 3 days, or if someone says I need it to be easier and preparation only be 15 minutes, I'm making special recipes that are modified for the person's genetic that meet all of their requirements.
There's a really great question here about inflammation. It's talking about inflammation resulting from carbohydrates and how that may affect other inflammatory genes. And absolutely, this is so key. And this is the whole integration of genes. So the question, like an example, is if they're variant for the ADRB2 gene, so they create more inflammation to carbohydrates, but they're normal for the inflammatory genes interleukin-6, TNF, and the detox gene, so they're clearing it out. Being normal for IL-6, TNF, and the detox genes, absolutely that's going to downgrade their inflammation greatly, particularly to pollutants or when they exercise. But that person is still going to create inflammation with carbohydrates, particularly inflammation within the fat cells, because that gene is where the ADRA receptors are more so in the fat cells. There's other ones where they're more in the cardiovascular section or in the cardiovascular system. So it will change where the inflammation is, and it will also change the amount of inflammation. So this person, when they eat carbs, although they're inflamed, they won't then trigger adverse reactions in the IL-6, TNF, and detox genes. Whereas if that same person was variant for ADRA2 and variant for all the inflammatory cytokine genes and the detox genes, that inflammation from the carb would then really trigger the variant allele within this IL-6, TNF, and detox, and that inflammation load will be huge. So that's where you have to take a look at all of the different sections within the GeneRx report and really look at the recommendations for inflammatory cytokines, etc. If a person is variant for those inflammatory genes and they are exposed to a lot of pollutants, or they have an infection which triggers IL-6 and TNF, and that starts turning those inflammatory genes off, and they're heterozygote or variant for ADRA, but not eating carbs, the inflammation from the cytokines can also start to trigger off that ADRA gene and gain weight from that. So you might need to rein their carbs in even more. And this is the art, the beauty, and the difficulty with integration of, but it is so key, and that was such a fantastic question.
Awesome. So I put a note to see if there are any last questions, and it doesn't seem like anything else is popping up. So for now, we'll probably sign off just to make sure we're being respectful of everyone's time. And really just thank you so much for being here today with us. And we look forward to having you on the upcoming webinars as well. Dr. Penny, anything?
No, I just want to wish everybody well during this difficult time. It is a time where, again, keeping our patients and ourselves healthy becomes more important than ever before. So I thank you for sharing this, well, for us, noon hour on this side of the country, morning for you guys over there. And I wish everybody to stay happy and healthy.
Awesome. Thank you so much. So we'll let you guys all go, and we'll see you next time.